Well, good morning, everybody. My name is Peter Wayne, and I'm the Research Director at the Osher Center for Integrative Medicine. Thank you all for coming to our research grand rounds today. Today we have a really special speaker and on a remarkable topic. Our speaker today is Dr. David Mischoulon, who is the Joyce Tedlow Professor of Psychiatry at the Harvard Medical School and also the Director of the Depression Clinic and Research Program at Mass General Hospital. And I've known David for many years now, and he's really uniquely qualified to give one of these Osher Center Integrative Medicine Grand Rounds. He brings together a whole bunch of very important skills that all meet in his activities. One is that he's a deeply skilled and trained and committed clinical psychiatrist and runs a depression clinic. But he also has not only an MD, he has a PhD in research, and he does really nice, cutting-edge, very rigorous research. And so he brings a very high level of standard to his interpretation and generation of the evidence. And then he's also very interested in helping patients who are interested in complementary and alternative approaches to treating psychiatric disorders. In addition to studying fish oils, David's done some research in acupuncture and a number of other alternative therapies. And I think he brings that blend of evidence and what's practical and what's safe. David's received a number of important awards. He has over 250 peer-review articles, and he also has an important textbook that brings this rigor and information to the public called Natural Medications for Psychiatric Disorders. Today, we're lucky to hear him talk about omega-3s and the treatment of depression. So without any further delay, please join me in welcoming David.
Thank you very much, Peter, for that nice introduction. Thank you all for coming today. It's nice to be here. So as you will see, the omega-3s are very versatile natural compounds that have been used in various branches of medicine, and I'm going to focus primarily on the psychiatric end of things. So I'm listing my disclosures. A number of companies have supported some of my research on omega-3 fatty acids, and I've done some consulting and received royalties for the book that Peter mentioned. It's still in print. I think it's getting to be due for a revamp soon, but hopefully we will. Let me start by making a few general introductory comments about the omega-3 fatty acids. In psychiatry, we're primarily interested in two types, docosahexaenoic acid, also known as DHA, and icosapentaenoic acid, or EPA. And these are long-chain polyunsaturated fatty acids, meaning they have many double bonds. And they're found primarily in fish oil, as well as in marine algae and other sources. And they're thought to function in many different ways in the human organism as well as in animals. And in particular, they've gained a great deal of popularity over the decades, primarily in cardiovascular illness and also in psychiatric illness. The reason that psychiatry became interested in the omega-3s is because it was known for a long time that parts of the world where there's a lot of consumption of omega-3, primarily through fish intake, such countries were usually associated with lower rates of depression. Other evidence suggesting the omega-3s had mood beneficial effects include the fact that deficiencies of omega-3s have been linked to depression. For example, alcoholism and the postpartum period, which are particularly vulnerable states and are associated with depletion of omega-3. Another thing that's interesting is that in our modern Western diet, we consume a lot of omega-6 fatty acids, which are those found in vegetable oils and processed foods. Historically, our ancestors tended to consume more omega-3 than omega-6, but we do the opposite as a general observation. The omega-6s primarily promote inflammation activity in the human organism, whereas the omega-3s are anti-inflammatory. And it's thought that perhaps this skewed ratio in favor of the omega-6 may create a pro-inflammatory state in all of us and make us more vulnerable not only to cardiovascular illness but to depression as well. Studies have shown that people with depression will have noticeable depletions in the omega-3s, particularly in the red blood cells and also in fat tissues. So the evidence suggested that the omega-3s may have beneficial psychiatric effects. As it stands right now, there's more than 30 published clinical trials examining omega-3s in mood disorders, particularly in unipolar major depression. Let me talk a little bit about how the omega-3s may work. In this schematic diagram of the neuronal synapse, we know that the presynaptic cell releases serotonin, dopamine, and norepinephrine, and these neurotransmitters interact with receptors and second messengers, which ultimately result in reactions that produce proteins that may ultimately have mood regulating effects. Still a bit of a mystery. The omega-3s have been shown to have some reuptake inhibition activity so that they increase the availability of these neurotransmitters, somewhat analogously to the serotonin reuptake inhibitors like fluoxetine and paroxetine and other antidepressants, the tricyclics with noradrenergic effects. So this is one of the proposed mechanisms of the omega-3s. The omega-3s are also thought to have mood-stabilizing properties, and some studies have shown benefit in bipolar illness, which I'll talk about. The omega-3s are very flexible molecules, and so they can easily intercalate their way into the neuronal cell membrane, and again, interacting directly with neurotransmitters and second messenger systems. In particular, they may interact with the phosphoinositide protein kinase system, somewhat analogously to the way lithium has been thought to exercise mood stabilizing properties. So this has been another mechanism that's been proposed for how the omega-3s may stabilize mood. Finally, as I mentioned earlier, the anti-inflammatory effects. So as you see in this diagram, on the left we have the omega-6 polyunsaturated fatty acids. On the right we have the omega-3s. So through various mechanisms, EPA will stimulate the synthesis of omega-3 derived eicosanoids, which are primarily anti-inflammatory, as opposed to the omega-6s, which will produce more of the pro-inflammatory cytokines. So this is the other major mechanism by which the fish oils and the omega-3s have been proposed to have mood-enhancing effects, as well as cardiovascular benefits. Now, after going over the background and mechanisms, now I'm going to talk more concretely about clinical trials that have been done, first in depression, and I'll also mention some in other conditions as well. One of the landmark studies that was done with the omega-3s in major depression was published by Pete and Horobin in 2002, and this was a dose-finding study of ethyl eicosapentaenoic acid. They used regimens of 1 gram, 2 gram, or 4 grams a day against placebo as adjuncts to standard antidepressants in people who were not responding to antidepressants. So they had 70 subjects, mostly female, and they were treated for 12 weeks. Among completers, they found that about 69% responded to EPA and only 25% responded to the placebo. So this is a very robust difference, which was statistically significant. In the intent to treat sample, the response rate for EPA was about 53% and 29% for placebo, again, statistically significant. What's interesting is that the optimal dose was actually 1 gram a day. 2 grams a day alone did not reach significance, and the 4 gram a day regimen only showed a trend to significance. So this suggests that there may be a therapeutic window for the omega-3s, and future studies that I'm going to mention will also support this idea. Again, this is the graphical representation. So we see here that the 1 gram a day had the strongest response rate in these individuals as opposed to the other regimens. Now, what about DHA, docosahexaenoic acid? DHA is less well studied than EPA, and so consequently it's harder to draw too many conclusions. One of the first studies of DHA monotherapy for depression was by Lauren Marangel and colleagues. This came out in 2003. Dr. Marangel used a 2 gram a day DHA regimen versus placebo as monotherapy in 36 patients who were treated for 12 weeks. In this particular study, they found no significant difference in response rates. DHA gave about a 28% response rate and placebo about 24%. DHA did show a modest advantage in mean improvements in the Hamilton scale, the MADRS scale, and also the Global Assessment of Functioning. But again, these did not reach significance. So the conclusion in this study was that the 2 gram a day were not significantly more effective than placebo. However, our group in 2008 carried out a dose-finding study of DHA, also monotherapy. And we used a strategy similar to the Pete and Horobin study, 1 gram, 2 gram, or 4 grams a day. And as we see here, both in completers in green and the intent to treat sample in blue, the 1 gram a day regimen outperformed 2 grams and 4 grams a day. This study was limited by the fact that we didn't have a placebo arm, so our only conclusions were based on the pattern of the different doses. But as you see here, it's quite a difference when you go from 1 gram to 2 and then to 4 grams, and this was suggestive that DHA may also have a window of therapeutic benefit. This would actually likely agree with Dr. Marangel's study because, again, the 2 gram a day regimen was not that effective, but 1 gram a day seemed to be the most effective. And this seems to be in line with the Pete and Horobin study as well. We followed this up with a study of EPA monotherapy for depression. And here we compared 1 gram a day of EPA against placebo in 71 subjects for 8 weeks. As you see here, by the 8th week, we started getting some separation between EPA and placebo. This did not reach statistical significance, unfortunately, because the sample was smaller than we had originally hoped to recruit. However, we did get a robust effect size of 0.73, so this was actually an encouraging result. Here we see the response rates. Again, the EPA had a stronger response rate than placebo and also a stronger remission rate. The odds ratios here were quite robust in favor of EPA. So while this study was limited by a small sample, I think the overall pattern suggests that EPA has an advantage. Another interesting finding in this study had to do with the fact that we examined serum lipid levels in our subjects. And we were interested in particular in whether the omega-6 to omega-3 ratio had any impact on treatment response. And what we found was that subjects who had higher omega-6 to omega-3 ratios at baseline tended to have a greater response to the omega-3 based on Hamilton D scores and also on response rates, and this was a significant finding. The idea being that if a person is following a diet that's high in omega-6 and having little omega-3, adding the omega-3 can have a greater impact than in a person who's already following a fairly healthy diet. For this reason, in most of our studies, we don't accept individuals who are already consuming large amounts of fish because they probably would not benefit from the additional omega-3. So in the omega-3 deficient subjects, they may be the ones who do best. The other interesting finding is that we followed the omega-6 omega-3 ratio during the course of treatment, and we found that the change in the omega-6 to omega-3 ratio was significantly associated with the change in the Hamilton D score. So in other words, the the greater improvement with regard to omega-3 seemed to be reflected in the depression scale improvement. So the idea inherent in this is that the ratio of omega-6 to omega-3 may be one of the mediators of clinical response. And then the next study that we did, we published in 2015. This was done in collaboration with Dr. Mark Rappaport's group at Emory University. So this was a two-site study. So for this study, we wanted to compare EPA against DHA and placebo. So we had almost 200 subjects with depression between the two sites, and they received EPA 1,000 milligrams a day or DHA 1,000 milligrams a day or placebo for 8 weeks. Now, the findings initially were rather disappointing in the sense that the response rates, as you'll see at the bottom, were about 50 to 60% for all three treatment arms, EPA, DHA, and placebo. So we didn't get any significant differences. I mean, everyone got better. Everyone had a robust improvement, but neither arm seemed to have an advantage over the other. However, as part of this investigation, we were also interested in the impact of inflammatory biomarkers, how they might be impacted by the omega-3 treatment, and what impact they might have on treatment response. So the question was, do baseline levels of markers of inflammation like C-reactive protein, interleukin-6, and others, do these somehow mediate or moderate the response to treatment? We found the following, that individuals who had no elevated markers at baseline tended to have fairly modest responses, particularly to EPA compared to placebo. Whereas those who had 4 or 5 elevated biomarkers, they did quite well. You see, the effect size for EPA compared to placebo was about 1.11, and this clinically represented was associated with a drop of 11 points on the Hamilton D scale for EPA versus 5 points for placebo. To give you some perspective, in a clinical trial, if you get a difference of about 2 points in the Hamilton D score between drug and placebo in a large sample, that's usually good enough for statistical significance and for FDA approval. So here we're talking about a difference of 6 points. So that's quite robust. We also found that individuals who had at least one elevated marker tended to be overweight as well. So this actually set the stage for the next study that we did. So we concluded that people with elevated inflammatory biomarkers may be particularly good subjects to receive EPA, and also individuals who are overweight, because the state of being overweight is associated with greater inflammatory activity. These individuals may also be good candidates for omega-3. So the next study that we did also with Dr. Rappaport, and we've just actually completed our last patient finally completed the study. So we recruited depressed individuals who were either overweight or obese based on the BMI, and who had elevated inflammatory biomarkers at baseline, on the theory that these people would be more likely to respond to EPA. So as I mentioned, we've just finished with our last patient. We're in the process of starting to analyze the data. If the results are in line with our hypotheses, this could help to further the evolution of personalized medicine by targeting specific populations that may be particularly well suited to respond to the omega-3 fatty acids. Okay, so that's the work that we've done in our group based on some of the early findings of others. Now I'm going to give a broader perspective by mentioning a few important meta-analyses that have been done. In meta-analyses, we lump together several different studies based on rigorousness and other factors, and try to get a sense of what's the big picture. What do the studies as a whole tell us? So as you can see here, in this meta-analysis that examined omega-3 levels, we see that they are in fact lower in people with depression. This applies both to EPA and to DHA. So again, this goes well with the hypothesis that people who don't consume as much omega-3 may be more vulnerable to developing depression. This was a study that a bunch of us did, another meta-analysis, examining what the different omega-3 preparations can do for you. And overall, based on these studies that we did, we found advantages, in particular for preparations where the EPA consisted of at least 60% or more of the total omega-3 content. Whereas in studies where there was less EPA, relatively speaking, you see the benefit was less. So this was actually supported by other meta-analyses as well. This other one examined whether omega-3 supplementation can reduce symptoms of depression. And in some of these, which were mainly DHA, and some of these which were mainly EPA, we see the EPA studies seem to have a greater advantage. If you're to the left of the bar, it favors the omega-3, whereas to the right, it favors placebo. Again, part of it, of course, may be driven by the fact there are many more studies of EPA than of DHA. So we need to take that into account. So overall, the studies as a whole tend to support the omega-3s, particularly EPA, as effective as an antidepressant. Now I'm going to talk a little bit about what we know about the omega-3s as potential treatments in other indications. My colleague Kwon-Pin Su from Taiwan examined the omega-3s in individuals who were going to receive interferon therapy for hepatitis C. So in his study, he used omega-3 as a prophylaxis. It's been known that because interferon treatment can produce depression, treating with antidepressants prior to beginning interferon therapy can have benefits, and I've actually done that frequently in my practice with good success. So in Dr. Su's study, they looked at 162 people who were receiving interferon for hepatitis C, and they were followed for 2 weeks and received either EPA, DHA, or placebo. And what they found was in those who received EPA, the incidence of depression was only 10% compared to 28% with DHA or 30% for placebo. They also found that both EPA and DHA could delay the onset of depression for up to 12 weeks compared to 5 weeks for placebo. So this is a very encouraging finding that, again, the omega-3s may have a potentially beneficial effect with interferon therapy becoming less popular now for hep C, with newer treatments having emerged. This kind of scenario may not present itself as often, but there will always be some patients who may need interferon, and omega-3s could be a potentially useful prophylaxis. Now, what about in bipolar disorder? Jerome Saris from Australia, who was a research fellow in our group and now directs his own program at the University of Western Sydney, worked with me and with Isaac Schweitzer, who was his mentor, on a meta-analysis in which we looked at 6 studies of omega-3s in bipolar depression. So these were cases of omega-3 plus some other pharmacotherapy or treatment as usual for 4 weeks or longer. And by and large, as you can see, the studies as a whole tended to favor omega-3 as a treatment, and the results were statistically significant with a moderate effect size based on the Hedges G statistic. So this was encouraging. Let's see. Sorry, this is come on. Yeah, so these are a few subtle points. The funnel plot is something that they use in meta-analysis to address the question of whether there's publication bias. Those of us who carry out a lot of clinical trials have probably had a few negative clinical trials where there is no separation between drug and placebo. And we know that those are generally more difficult to publish. And so consequently, what you see in the literature may be skewed in favor of studies that showed positive results. So the funnel plot is a strategy for telling you how much publication bias there may be. In this particular case, we found that there didn't seem to be a significant likelihood of publication bias. So the data that are in the literature seem to reflect reality. Now, what about in mania? The same group here, we examined this in 6 studies. We found that there was a non-significant trend supporting the omega-3s as potentially useful for mania, but the effect size was much more modest, about a 20. And in the largest study in the group by Keck and colleagues, the results were non-significant. Again, here we didn't find significant publication bias either. But overall, the results were less encouraging with regard to mania. I'll say more about the omega-3s in bipolar individuals later on. Now, what about in postpartum depression? There are a number of lines of research by Marlene Freeman, who's now at MGH, and Lauren Marangel, whom I mentioned earlier. Now, they've examined the omega-3s in postpartum depression, and in Dr. Freeman's study, they used a dose-finding design of 0.5 gram, 1.4, or 2.8 grams a day of an omega-3 mixture in 16 women with postpartum depression. By and large, they found some robust findings for the Hamilton D-score and the Edinburgh postnatal depression scale. But again, all the treatment groups seemed to have improvement. There didn't seem to be a dose response effect, which suggests that perhaps modest doses, of as low as 0.5 grams a day may be satisfactory. Lauren Marangel was interested in whether the omega-3s could prevent postpartum depression, and she used higher doses, almost 3 full grams a day of an omega-3 mix in a small sample of pregnant women. In her case, she didn't find a significant effect. I think these studies are limited primarily by small samples, and actually doing research on postpartum depression can be challenging from the standpoint of obtaining funding. The same applies for treating depression during pregnancy. The omega-3s could potentially be beneficial for pregnant women, and I'll say more about that later. But it is a challenging area. Hopefully, more studies of this sort with larger samples will eventually be carried out. What about in children? In general, most of the natural products that I've studied are not that well studied in pediatric or adolescent populations. This is a good study that came out in the American Journal by Nemitz and colleagues, showing that the omega-3s seem to have a benefit in depression over placebo. Again, this was a small sample of 28 children, but overall statistically significant findings, and overall very encouraging. The omega-3s have also been studied in psychotic disorders, particularly schizophrenia. Fenton and colleagues examined a dose of EPA of 3 grams a day in schizophrenia and schizoaffective disorder in 87 subjects for 16 weeks. They didn't find a significant benefit. Pete and Horobin, who had published the study of EPA in depression, followed a similar dose-finding strategy, 1 gram, 2 gram, or 4 grams a day versus placebo in schizophrenia. And they studied 115 subjects for 12 weeks. They found that 2 grams a day were effective, particularly in the positive and negative symptom scales, but the placebo effect was high. So the treatment arms did not separate from placebo. Another interesting ancillary finding was that the higher doses of omega-3 decreased triglycerides in patients who were taking clozapine for their schizophrenia. Clozapine is notorious for causing weight gain and triglyceride anomalies. So there may be some general health effects in this population, but as far as clinical treatment, the data aren't so strong. There's a study by Pavelchik that came out not too long ago that suggests that omega-3 treatments may have preventive effects. If you have a high risk of schizophrenia, say if there's a history in your family, supplementation with omega-3s may have preventive effects, but this work needs to be replicated. Mary Zannarini at McLean Hospital studied the omega-3s in a sample of patients with borderline personality disorder. In this case, she studied 1 gram a day of EPA against placebo in 30 women. And what they found was the EPA seemed to have an advantage over placebo on certain scales. For example, aggression and depressive symptoms seemed to improve, but placebo also produced some benefit. As you can see on the MADRS scale, for example, there was a drop from 17 to 6 with EPA, but with placebo there was also a drop to about 8. So it seems like everyone had some benefit. So in these cases, it becomes difficult to rule out how much of the improvement has to do with a placebo effect or patient expectations of improvement. What about self-harming behavior? Hallahan and studies and colleagues looked at 49 patients who had a history of repeated self-harm, and they were randomized, in addition to standard care, to EPA plus DHA versus a placebo. And the omega-3 group had a significantly greater improvement in depression and suicidal ideation and daily stress. Another interesting study by Lewis and colleagues in Joseph Hilborn's lab at the IEEE, they found in a military population that those who had lower levels of omega-3 in the blood were more likely to commit suicide than those who didn't. There seems to be about a 14% higher risk in those who had lower DHA in the blood, and this was especially notable among men. A 62% greater risk of suicide death if your DHA status is low. Interestingly, they didn't find quite as robust an effect for EPA. So this suggests that while EPA may be better for acute treatment of depression, DHA is also important and may have effects specifically on suicidality or on those aspects of depression that are more directly linked to suicidal behavior. There have been some other studies examining the omega-3s in attention deficit disorder and obsessive compulsive disorder. These investigations are generally more preliminary. They have smaller samples. There seems to be some benefit in ADD, but some other studies have not been so encouraging. At this moment, we don't generally recommend the omega-3s for ADD or OCD, at least not as monotherapy, but perhaps as an augmentation therapy with other treatments. They may have some added benefit, but we need to do more work on this. Now, what about prevention of depression and the omega-3s? My good colleague Olivia Okereke, who was actually at Brigham and Women's for a long time and recently moved back to MGH, is leading a very interesting study called Vital D, in which I've been very lucky to have the chance to collaborate. So what we're doing is looking at a very large number of healthy men and women, age over 50 for men and over 55 for women. And they've been randomized to either vitamin D plus EPA or vitamin D plus placebo or placebo plus omega-3 or placebo plus placebo. So it's essentially a 2x2 grid. So the question asked in this study is, can supplementation with vitamin D and or omega-3 prevent depression in older individuals who are healthy at the start? In other words, these individuals don't have any active depression at the time of admission. This study is also getting close to completion, and hopefully in the months to come we'll have some results. So it'll be a very exciting study. If it does show benefit, it could have a very significant public health impact, because it might lead to recommendations about supplementation with fish oil or vitamin D in healthy people over 50. Let me now talk a little bit about safety considerations with the omega-3s. Historically, the most common side effects were stomach upset and a fishy aftertaste. particularly with higher doses of omega-3 of 5 grams or higher, and with less pure preparations. Nowadays, most of the commercially available omega-3 preparations have been more highly purified, so we get fewer complaints of that type. The omega-3s are very safe to combine with most other medications. They can be combined with antidepressants and with most other things without significant adverse interactions, which again is a good argument for using them as an augmentation therapy in people who haven't responded adequately to standard antidepressants. Historically, there was a concern about bleeding with higher doses. But recent data suggest that those concerns may have been exaggerated and that it's probably safe for most people to take high doses of omega-3. However, in certain populations, there are cautions that are still active. For example, if you're taking anticoagulants or have a bleeding disorder, you may want to be cautious about omega-3s. Likewise, if you're going to have surgery, don't be surprised if your surgeon tells you to discontinue the omega-3s a couple of weeks or so before the surgery. Generally, with doses less than 3 grams a day, there were never any serious concerns. So in patients who are taking more than 3 grams a day, the physician or nurse practitioner supervising them should be observant about that. Another concern is that although the omega-3s have been studied and used in populations with bipolar disorder, there are several case reports of cycling occurring, the way it can happen with any antidepressant. So in general practice, if the patient with bipolar depression is interested in omega-3s, I recommend using them cautiously and preferably with a concurrent mood stabilizer to protect the patient against cycling to mania. Now I'll make some concluding remarks. As you can see, there's been a lot of work done on the omega-3s in the last 2 decades or so. As it stands right now, most of us who use the omega-3s in our psychiatric practices tend to use them as adjunctive treatment. In general, that's what the literature tends to support, although, again, there have been studies with monotherapy of EPA or DHA that suggest benefit. So certainly they can be used either way. In terms of the body of evidence, I would like to see more studies of the omega-3s as monotherapy against placebo. And also, I'd like to see comparisons against standard antidepressants. We don't really have any studies like that right now. And it would be good to see how do the omega-3s fare against the SSRIs or SNRIs and the antidepressants that we typically use in psychiatric practice. Earlier, I spoke about some of the major meta-analyses, and one of the limitations of these meta-analyses is that the studies that I've cited here tend to vary quite a great deal with regard, for example, to the type of preparation used, how much EPA versus how much DHA, what doses are used. Some studies use as little as 0.5 gram and some as much as 6 to 10 grams a day. And so that renders interpretation difficult. Likewise, study design issues can also make it hard to generalize from the meta-analyses. One particularly concerning issue for the believers in the omega-3s is that as more studies have emerged that are more methodologically rigorous, the effect size seems to have decreased somewhat, which suggests that as the studies get more rigorously done, we may find that the effects of the omega-3s are more modest. So that's something that I'm particularly watchful for. However, I am glad to see that there are more rigorous studies emerging, because in my field of complementary medicine, one of the major limitations of the research is that many of the studies that have been done are really not very rigorous. And consequently, it's very hard to interpret the findings and make recommendations based on clinical research that's not really of the highest quality. So hopefully that'll change in the years to come. I think another lingering question is what about EPA versus DHA? Is EPA better than DHA in mood disorders, or for what aspects of the mood disorders? By and large, the meta-analyses seem to suggest that in more severe major depression, EPA might be a better choice. There's the Appleton meta-analysis and the Sublette analysis, which was the first one to show that preparations of at least 60% EPA relative to DHA were apparently more effective. On the other hand, there's the Lewis study that I mentioned that seems to suggest that DHA has a protective effect against suicidal behavior, which obviously in a psychiatric population with depression it's of utmost concern to the treater. So my feeling is that both EPA and DHA have a role to play as far as treatment of depression and preventing suicide. We need to characterize these roles more, and so we need to understand better what exactly these omega-3s can do. So I'll end with a few clinical recommendations. For those of you who may be considering using the omega-3s in your practice or who have patients who are already taking them, I think certainly using them as monotherapy or adjunctive therapy in unipolar depression, I think is a pretty good bet. You can certainly do that without much concern. And in bipolar depression, you can probably use them as adjunctive therapy, but with caution, because you do want to be alert for any cycling to mania. As far as treating mania with omega-3s, I'm not so impressed with the evidence as a whole, and I would not recommend the omega-3s in the bipolar manic patient. Those patients should be treated with mood stabilizers and/or antipsychotics until they stabilize. And the omega-3s could be introduced during a depressed phase of the illness. As far as dosing, obviously, if a person consumes fish, say salmon or tuna, the omega-3 rich fish, about 3 times a week, that's about the equivalent of ingesting about 1 gram a day of omega-3. So if you're a fish eater and you're eating fish about 3 times a week, you're probably fine. If you don't and would be interested in supplementing, somewhere between 1 to 1.5 grams of EPA and DHA, again favoring EPA in the distribution, that might be the best bet for the individual who's concerned about depression, either preventing it or treating it acutely. Also, in patients with cardiovascular conditions, there may be benefits, and so even if the omega-3s don't necessarily have an effect on an individual's depression, they may still obtain other health benefits from supplementation. In elderly people, the omega-3s may prove very helpful. We do worry about antidepressant-related side effects in elderly patients. If the omega-3s could be an alternative to standard antidepressants or be used with standard antidepressants and prevent the need for very high doses of the standard antidepressants, that could be beneficial. We'll see what Dr. Okereki's study shows about prevention. And finally, with regard to expectant mothers, now, we know that the omega-3s, especially DHA, are very important for the fetal brain development, as well as for other things like allergy prevention. The state of pregnancy ultimately depletes the mother's omega-3 supply because it's all mostly shunted to the baby. There's reason to think that supplementation in pregnant women, particularly those with depression, may be beneficial. Certainly, the FDA has finally given its approval to fish consumption during pregnancy. There used to be concerns, about mercury and other things, but by and large, at this point, the FDA feels that fish consumption is safe. So, in theory, supplementation with omega-3s could also be of benefit. The main concern with pregnant women is that we don't know what might be the safe upper limit of dosing. So for that reason, in clinical practice, we do advise caution. And if a pregnant woman with depression is interested in treatment, my inclination is still to go with treatments like the serotonin reuptake inhibitors, which have been proven to be safe and effective during pregnancy without potential damage to the unborn child. But ultimately, it's a very personal decision that should be discussed carefully between the doctor and the patient. So finally, I'd like to acknowledge my mentors in the depression program, Maurizio Fava, Andy Nirenberg, and John Alpert, who recently became chairman of psychiatry at Albert Einstein, and my colleagues at Emory University, with whom I've done a good portion of these clinical trials I talked about, Mark Rappaport and his associates. Also, Olivia Okereke and Chip Reynolds from the University of Pittsburgh and Grace Chang, who are working together on the VITAL study. Jerome Saris from Western Sydney University and Quan Pin Su from China Medical University. All their work has been cited here, and I've been very honored to collaborate with them. And finally, I want to thank all of you for being here. Thank you.
Well, thank you. Would you entertain some questions?
Yeah, happy to, please. Sure. Hey. Yeah.
Jessica will shepherd that around.
Thank you, David, for a wonderful presentation, and congratulations on your body of work thus far. My one question, I was just thinking the one point that you didn't mention in your clinical recommendations but alluded to earlier was around the personalized medicine. So I know there's the study is whether risk factors, you can use risk factors to guide treatment plans. Do you currently, though, as a clinician, use that sort of approach to say, are you obtaining some of these biomarkers to see if somebody may or may not respond to omega-3s?
Yeah, it's a very good point. No, for the most part, these biomarker tests are not widely used in clinical practice, although increasing numbers of patients are going to commercial labs where they will get tests for cytochrome P450 polymorphisms, methylene tetrahydrofolate reductase, MTHFR deficiencies, and also some of the inflammatory biomarkers. So many people are coming in to my practice with their profile in hand and asking, what can you do about this, sir? I think we need to learn more about how good these are as predictive markers. George Papakostas published a study a couple of years ago where they looked at 9 or 10 biomarkers of different sorts, including some for inflammation, for example, and they found that taken together, those biomarkers could identify, populations with major depression. But we still have a good bit of work to do before that we can start using them as a tool to guide our treatment. Andy Nirenberg is actually doing a study in which he's actually going to compare treatment as usual in depression versus treatment guided by these genetic profiles from one of those companies. So depending on what happens, the doctors will either use that genetic guide based on the polymorphism. So for those of you who aren't familiar, those genetic profiles will ultimately give you a list of green, yellow, and red light antidepressants or antipsychotics. So the ones in the green light area, those are the ones you would want to use preferentially. Yellow you can use, but not the best. Red you probably want to stay away either because they may not work or they may be prone to causing side effects. So I think Andy's study is going to be very interesting in getting a sense of whether do these biological profiles really result in better outcomes if they're followed by the clinician. So I think in the next few years, I think some of these approaches will start to help guide clinical practice and help develop personalized medicine.
Thank you for a great presentation.
Thank you.
I'm just wondering how the dosing recommendations on a commercially available bottle of fish oil align or not with these data.
Yeah, very, very good point. When I recommend omega-3s to patients, I tell them you need to read the label carefully, because a typical, commercial preparation of omega-3 you might find at the CVS will say, 1,000 milligrams of omega-3 per capsule. But you might find that only about 300 or 400 milligrams are actually EPA or DHA. the rest of it consists of other omega-3s. Just to make a comment, flaxseed oil is another popular omega-3. And although it has cardiovascular benefits, there's not a lot of evidence of it being effective in mood disorders. It just hasn't been studied, in detail. So what I tell people is that if the goal is 1,000 milligrams of EPA plus DHA, then you need to adjust the doses accordingly. There are some of the higher quality brands. For example, the ones that we use in our study are made by Nordic Naturals, and the Nordic Natural brands has some highly concentrated ones that actually have 1,000 milligrams of EPA or DHA. They have a whole line of products. And we actually, as a condition for obtaining the funding, we had to have the preparations vetted by 2 independent commercial labs to make sure that what they claimed to be in the capsules was there. Fortunately, they were. So I think reading the labels is important, and many patients may need to think about, do they want to invest in some of these, what I call Cadillac brands that are more expensive but have more of the active ingredient. But yeah, I do specify that you have to make your adjustments for the amount of EPA and DHA in the preparation, and not just assume that if it says 1,000 milligrams of omega-3, that's gonna take care of it. It may or it may not.
Thank you.
Oh, thank you. It sounds like from the data you presented, it may be that what's most effective is in fact correcting a deficiency rather than using the omega-3s as a actual drug or, Do you have any thoughts on that? And also, what would be the mechanism by which more may not be better?
Okay, so I think you're right in that most of us are probably deficient in omega-3s unless we eat a lot of fish. How many people here eat fish on a regular basis? Okay, a few of you. All right, good. Yeah, I like fish. I'm just not as good about eating fish as much as I should. I actually take omega-3 supplements. It shows that I'm a believer. But I do think the average citizen in the industrialized world, particularly in the United States where fish isn't that popular, is probably deficient in omega-3s, and not to mention the fact that we tend to consume processed foods. So in a sense, what we may be doing when we treat these people, we're simply correcting a deficiency and shifting the ratio in a direction that maybe reflects more what our ancestors consumed. On the other hand, what about is there a risk of overcorrection? Possibly. Certainly, the fact that in the Pete and Horobin study and in our study, we found that higher doses of omega-3 didn't work very well for unipolar depression suggests that there's a therapeutic window for it. And maybe that has to do with the fact that inflammation and the omega-6 fatty acids are not bad things. I mean, they're part of our system. They're necessary. We need to be able to mount an inflammatory response under certain conditions. I think the idea is that there's a sweet spot. You want to have a balance of inflammatory and anti-inflammatory activity. And maybe too much anti-inflammatory activity may not be good for us either. How that impacts on mood, that's still a mystery. But I think what I take home from a lot of these studies is that there's a therapeutic window for how we use the omega-3s. So we don't want to overdo it either.
Thank you again so much. I'm just curious, you mentioned briefly the use of fatty fish for omega-3 or vitamin D intake. Have there been studies to your knowledge looking at the effectiveness of supplementation versus actual food sources?
As far as comparisons of supplementation versus food sources, not that I know of. However, there's a recent study by Felice Jacka from Australia who examined the Mediterranean diet as a means of treating major depression, and she found that there were benefits to using the diet. So I think there's reason to believe that a good dietary intervention could do the trick for depression. How does it compare against supplementation? We would have to study that head to head. one of the things Felice Jacket talked about when she came to visit us a couple of years ago was that recruitment at times was a bit of a challenge in the study because a lot of people may be reluctant to change their lifestyle, and certainly from the standpoint of omega-3, taking an omega-3 capsule every day may appeal to a lot of people more than eating fish. The Mediterranean diet is a very good diet, and it's great for a lot of people, but not everybody necessarily is eager to adopt it, especially in the United States. In Australia, they may be more open to it. So I think a study like that, it'd be interesting to see what would happen if we did a study like that in the United States. I think we can do a lot more for ourselves by eating healthily. It's just that getting people to do it is hard. It's like exercise. Exercise has been shown to have beneficial effects on mood, but getting a depressed patient to exercise, to do any kind of physical activity is difficult. So I hope we'll have more studies looking at dietary interventions as opposed to supplementation.
Actually, since you mentioned exercise, that was one of my questions. Are there any discussions of looking at interactions? Because we know if we can get depressed people to exercise, it has some good mood effects. And there may be some anti-inflammatory mechanisms there as well. I'm wondering if in your clinical treatments or in terms of research plans where there's looking at interactions between supplementation and exercise.
Yeah, we're actually doing some research on heated yoga right now for depression. So we're recruiting people with major depressive disorder, and they're going to do the Bikram style of yoga where you're in that 110-degree room and you do 26 poses over 90 minutes. One of the things we liked about it is that because it's a very standardized yoga practice, it's wonderful for a clinical trial because everyone has to do the same thing. We're measuring inflammatory biomarkers in that study, and in that particular study, we do allow people who are taking antidepressants or other supplements to continue taking them because this is a pilot study. So we'll get a sense, hopefully, by adjusting for what types of antidepressants or other supplements were on board, we may get some insights about synergistic effects. In the long run, we hope to do studies, using yoga as the monotherapy, or using it in combination with a pre-selected supplement or other treatment. But we have a ways to go with that. But hopefully within another year, we'll have results for the yoga study.
Well, I think we're out of time. But I want us all to thank Dr. Mischoulon for such an excellent and comprehensive talk.
Thank you. Thanks very much.
And I also have a few announcements to make. Of course, at the end of each of these grand rounds, there is an opportunity to get together and have some tea and coffee and continue this conversation. So please join us. It's just out the door to the right. I also want to remind people about our upcoming Integrative Medicine Network Forum, which is on November 16th in this year at the Martin Center. And the focus of that is going to be genetics, epigenetics, and lifestyle. And we have some fantastic speakers lined up, including Dr. Okerke, and Dr. George Church is one of our keynote presenters. So please join us for that. And along those lines, we have our abstract submission open, and we hope that members of this community and your colleagues will submit an abstract for a poster. There's some awards. It's a great opportunity to share your work in this area, and also for your more junior researchers and research assistants. It's a great opportunity to get some practice presenting your work. So please look at our website at the Osher Center and consider submitting an abstract. So thanks again. We have another session coming up next month, first Tuesday of every month. We have a little bit of a schedule juggle, so it's going to be a surprise, but we'll make that announcement to you guys soon. So thanks again for coming, and thank you again, Dr. Mischoulon.
Thank you.